So the next talk is by Dr. Benedict Nwachukwu, and he's going to talk to us about the radiological assessment of dysplastic hip and some advanced imaging techniques. Thank you very much.
Okay, so I'm going to be discussing radiological assessment of dysplastic hip, as well as some advanced imaging techniques. I do not have any relevant financial disclosures. Slides credited to Dr. Ernest Sink, who I do my scope PAOs with. So, as Andrea mentioned, the evaluation of a dysplastic patient really begins with extensive history observing the gait, and then performing the supine and prone provocative maneuvers. But then transitioning to radiographs. In my practice, I use a series of radiographs: standing, AP pelvis, lateral of the proximal femur, false profile, MRI, CT for surgical patients, and in some cases ultrasound with injection, and I'll discuss these today. The AP pelvis really is the workhorse for hip preservation. It's the view that we measure a lot of our angles for dysplasia. I will traditionally get a standing AP. Standing AP, gives me a better assessment of acetabular version compared to a supine AP, and you can see that in this same patient, you can get a better sense of acetabular retroversion with the standing AP. And then, as with all hip pathology, you want to make sure that you understand the lines of the pelvis and how it relates to the specific pathology that you're dealing with, as well as other things that you may not think about, such as traumatic injuries. I would say that probably the most commonly measured angle for dysplasia is the lateral center edge angle. This measurement is typically made by drawing a line perpendicular to the axis of the pelvis through the center of the femoral head and connected to the lateralmost portion of the sourceal. Normal is between 25 to 40. Borderline is 20 to 25, although many would argue that 18 to 25 should be characterized as borderline dysplasia. We know that there is good literature that having borderline dysplasia as well as frank dysplasia increases your risk of progression to osteoarthritis, and these are patients that we pay particular attention to with measurement to the lateral center edge angle. Next angle that we commonly use is the Tonus angle. This is the transverse axis of the pelvis connected to the inferior medial sourceal and the lateralmost portion. Normal being between 0 and 10, and anything higher than 10 being suggestive of dysplasia, less than 10 pincer. A newer angle that's used is the femoroepiphyseal acetabular roof index, or the FEAR index. This index is calculated based on the angle between the acetabular roof and the central third of the femoral epiphyseal growth plate. And some clinicians will use this for evaluating the borderline dysplastic patient, sometimes a frankly dysplastic patient. A FEAR index of 0 means that the epiphyseal growth plate is perpendicular to the joint, suggesting a stable hip, and then a FEAR index greater than 5 predicts instability. And so a case study of the application of the FEAR index being, two patients with a lateral center edge angle of 20. Patient on the left has a FEAR of 0, and patient on the right has a FEAR of 8. And in the hip on the left, you may consider doing an isolated arthroscopic intervention, with a stable congruent joint. Very important to evaluate for presence of crossover when evaluating for a dysplastic hip. A normal hip, normal anteverted acetabulum, the anterior rim is medial to posterior rim, and crossover can indicate some acetabular retroversion. In the dysplastic hip, as with most patients presenting with hip pathology, I will get a lateral view. In my practice, I'll get the 45-degree done with the hip in 45 degrees of flexion and 20 degrees of abduction. I'll also get a false profile. False profile can be helpful for measuring the anterior center edge angle, as well as for evaluating for some early signs of arthritis that you otherwise wouldn't see on an AP pelvis. And then, as Andrea mentioned, even in dysplastic hips, it's very common to get irregularities of the femoral head neck junction with cam deformities, flattening and asphericity of the femoral head. And then MRI is quite critical for dysplastic patients presenting with hip pain, helpful for evaluating for the cartilage, the labrum, as well as soft tissue and other pathology. There are some pathognomonic findings in patients with dysplasia on MRI. You will commonly see labral hypertrophy, as well as some hypertrophy with iliocapsularis and high position of the fovea. And then in certain patients, specifically, obviously I'm a surgeon, so patients that where I'm thinking about surgery for, I will get a CT scan, allowing me to evaluate for acetabular version, femoral version, and then to get a three-dimensional assessment of the cam morphology, as well as occult acetabular deficiencies, so posterior wall deficiencies. And then in the failed hip arthroscopy, a CT scan is critical to evaluate for any residual impingement and to understand where there are deficiencies in the acetabular wall to plan possible open procedure. Thank you.